Good afternoon. Thanks for joining us Across the Fence. I'm Fran Stoddard. Today we feature another segment in our ongoing series of programs on cancer and your health. Our series is in partnership with the University of Vermont Cancer Center, which allows you to hear directly from medical professionals who are experts in their field. In this program, our focus is on the #2 cancer killer in the United States. You may already know that lung cancer is the #1 killer and that pancreatic cancer is #3. But the second leading cause of cancer deaths nationwide is colorectal cancer. And joining me are two experts from the UVM Cancer Center and the College of Medicine. Dr. Jeremy Dressler is a colon and rectal surgeon, and Dr. Chris Anker specializes in radiation oncology. Good afternoon to each of you, and thank you both very much for being with us.
Thanks for having us.
Good morning, thank you.
So I want to start with a picture to ensure that we're on the same page when discussing colorectal cancer. So we'll put up that image, and Dr. Dressler, if you can take us through some basics of the anatomy here.
Sure, and thanks, Fran. So in terms of basic anatomy of the colon, I like to think of it in terms of flow of the food we eat. So typically digested food comes from the small intestine and enters the colon in the lower right side near the appendix, and then travels up towards the liver, across the belly, and then down the left side where it enters the rectum before it exits the body. Now, the function of the colon is very critical. It helps break down digested food even further, as well as absorb water and electrolytes. And at the heart of this is the lining of the colon, made up of millions and millions of cells. Now, these cells have a relatively short lifespan and have to divide and turn over rapidly. And it's this rapid division that puts the lining of the colon at risk for development of polyps and cancer.
Oh, so interesting. And so in the introduction, I mentioned that the fact that colorectal cancer is the second leading cancer killer in the country, but how common is it, Dr. Anker?
Good question. There are over 130,000 cases nationally per year, and with an average person having a risk of about 4% of getting colorectal cancer in their lifetime. In 2020, there were about 52,000 deaths from colorectal cancer, and slightly more men than women, with 28,000 men dying and 24,000 women. And for comparison, there are 136,000 deaths from lung cancer and 42,000 breast cancer deaths. And your risk of colorectal cancer doubles if you have a first-degree relative who has this disease. And first-degree relatives are like parents, siblings, children. And the good news is that overall, both the number of cases of colorectal cancer is decreasing, as are the number of deaths. However, we are seeing more colorectal cancer in younger patients. And it's important to know that if detected early, over 90% of cases are curable with proper screening. And we can talk more about that in just a moment.
Terrific. So clearly, if you're related to somebody who you know has had this cancer, you want to be very diligent. And what kind of symptoms are there symptoms of colorectal cancer that can act as a tip-off?
So this is a really important topic to bring up because most colon cancers early on don't have symptoms. This is why screening is very crucial in detecting cancers before they become more problematic. But if patients do develop symptoms, what we typically see are things like change in bowel habits, so constipation, or something called tenesmus, or the feeling of frequently having to move your bowels. We see patients present with blood in their stool, as well as dark stools. They can have low blood counts, they can have nausea or vomiting, abdominal pain, weight loss, loss of appetite. There's a lot of symptoms that can come up. I would like to have people keep in mind, though, there are a lot of other conditions that can also cause these symptoms.
Right. So what can one do to decrease the chances of getting colorectal cancer? Dr.
Great question. Yeah, great question. Thanks, Fran. Eating a low-fat diet, rich in fruits and vegetables, avoiding excess alcohol, quit smoking if you are, exercise, and screening.
Okay, so let's move to screening then. What methods are there, and how useful and important are each one? Dr. Dressler.
Yeah, so there's a few different methods we use for screening. Probably what people are most familiar with is something called a colonoscopy, which is a same-day procedure where you come into the hospital or a surgery center, and we use a camera to look on the inside of the colon. We recommend for average risk patients that they have this done every 10 years. However, there's some alternatives. And it's important to note that all screening tests do detect cancer with similar efficacy rates and prevent cancer-related death with similar efficacy as well. There are two stool tests that we use. These can be done at home. One stool test does detect for blood. The other detects for a combination of blood as some certain DNA markers. Both of these we recommend being done every year if you choose to go down this path. If either of these tests do come back positive, the next step would be a colonoscopy to look in the lining of the colon for a polyp or a mass.
Great.
Yeah, go ahead.
I suppose that people would talk to their primary care physician about when to start, but what are your recommendations about who should get a colonoscopy and when they should start, or when they should be getting these other tests?
All right, this is a very important question. So recently, colorectal screening guidelines dropped so that anyone should be getting a colonoscopy by age 45, instead of the previous recommendation for age 50. And this age is even earlier for higher risk patients, such as those patients that we discussed earlier with a family history. And those patients, for example, should be getting a colonoscopy 10 years before their first degree relative got it. And this change happened because not only are younger patients being diagnosed more frequently, but they're often being diagnosed with more advanced cancer, just emphasizing the importance of this earlier screening age. And we're certainly seeing this in our own practice at UVM. It's common for younger patients to think that these symptoms that Jeremy described earlier might be due to some other reasons, but it might actually be colorectal cancer. And we want to help people avoid a delay in diagnosis. And people should really talk to their primary care provider to determine when they're supposed to start screening, because it might be earlier than they expect.
Right, so it could be 45 is not recommended, but it could be earlier if there is some cancer in your family. So
Yes.
most viewers have actually undergone a colonoscopy. I have, and we know that a camera goes up our colon, allowing a doctor to see, but what are you seeing? What are you looking for when you're performing those screenings?
Yeah, so what we're looking for, as you mentioned, we're looking for cancers, which are usually large masses that we see with this flexible camera. But also what we're looking for are tiny polyps. And these can range in size from an inch to even smaller, less than the size of a pencil eraser. And what's nice about colonoscopies is we can actually remove these polyps at the same time. So not only are we detecting cancers, but we're actually preventing cancers from even forming by taking these polyps out.
Terrific. And it seemed that, I guess, the colonoscopy rates dropped during the pandemic. People weren't kind of going to hospitals. Were you concerned about that? Are there other barriers to people getting a colonoscopy? Are people putting it off for some reason? Dr. Baker, go ahead. Dr. Ressler.
Yeah, certainly COVID has impacted the way we do things, but I would say at this point we're up and running with our screening program here at UVM. So, barriers that we see are the logistical in nature, where you have to take a day off from work, you have to come to the hospital. But I would argue that the benefits of screening, vastly outweigh the problems of the logistical side.
Okay, and so you respectively represent surgery and radiation oncology at the Cancer Center. Can you share with us what role each of those treatments play in colorectal cancer? And we'll start with you, Dr. Dressler.
Sure. So as a surgeon at UVM, it's important to differentiate between colon and rectal cancer here. For colon cancer, surgery is almost always indicated as the first treatment for patients. Here at UVM, we offer minimally invasive surgery for colon cancer. So that's a combination, or both laparoscopy and robotic surgery. And what that lets us do is remove colon cancer through very small incisions, which decreases the time of recovery and decreases the risk of complications. Here at UVM, we have an enhanced recovery protocol, which has further reduced our complication rate. And once someone is recovered from their operation, then they may need to see an oncologist for the discussion of additional treatment, such as chemotherapy. When it comes to rectal cancer, surgery is important. However, we use a team-based approach and include our oncologists, both medical and radiation oncologists, in the decision-making process for determining the best care for our patients. And I'll defer to Dr. Anker here because this is getting into his specialty.
Okay, great. Dr. Anker.
Thank you. So it's important for patients and healthcare professionals to make decisions together with full knowledge of the outcomes, not just with regards to the cancer control and hopefully eventual cure, but also quality of life. So while earlier stage cancers may be treated successfully with surgery alone, more advanced cancers might benefit from additional treatments such as chemotherapy and radiation. So radiation therapy is a high-powered X-ray delivered by a machine outside the body that basically causes cells to self-destruct when they try to grow, and chemotherapy further hinders cells' ability to grow, and they die when they try to do so. Colon cancer patients might be offered consultation with a medical oncologist to discuss chemo if they're high enough risk. Radiation therapy is rarely indicated for those patients. For rectal cancer, we've participated in research here that has shown that less aggressive approaches can be as effective and lead to better quality of life outcomes than the old standard, which always involved radiation, chemo, and surgery for every patient. And so, for example, chemotherapy, given after surgery is particularly hard on patients without much benefit, but if it's given beforehand, it might decrease the chance for distant metastases, distant spread of disease, and that might improve survival. And also, even better is that patients might be able to avoid surgery entirely if the cancer in the rectum is killed off completely by chemotherapy and radiation. And just the improvements in quality of life can be pretty dramatic with avoiding surgery, and they can better preserve their independence. And not every institution has the expertise to provide this option, so it's important for patients to know what options are available at the local institutions and elsewhere. And also, as we talked about younger patients, it's just important to know what options are out there possibly to help preserve their fertility as well.
Fantastic, and we really want to encourage everyone to take proactive steps in protecting their health, including life-saving screening available for colorectal cancer. Here are 2 online resources that can provide additional information. There's always the National Institutes of Health at cancer.gov. You can also find information from the UVM Cancer Center by going to vermontcancer.org. Doctors Jeremy Dressler and Chris Anker, thank you so much for sharing your expertise with us this afternoon.
Thanks for your time, Fran.
Of course, and thanks for having us.
And thank you for joining us across the fence. We hope you get your screening. I'm Fran Stoddard. Stay well.